Welcome guests, welcome attendees. Good morning, good afternoon, good evening, depending on where you are in the world today. Many thanks for joining us on another episode of the Digital Health Institute for Transformation's DHIT Frequency. DHIT Frequency is a web series and podcast that allows for health transformers, problem solvers, innovators to come together to discuss best practices, next practices, and all key advancements in the space of digital health. I'm your host, co-host, Michael Levy, DHIT's president. I'm co-hosting with the wonderful Kathy Mallis, associate CEO and head of innovation in AI for the Center Hospital of the University of Montreal. Welcome, Kathy. So thankful for you to continue on our journey here in season 3 and co-hosting with me today.
Same here, Michael. Thank you, and thank you, DHIT, for the invitation to co-host this series of DHIT Frequency.
You bet. Look, before we jump into today's session, last episode, our first co-hosting together was just so topical and emotional. We discussed the topic of the day was mental health. Maybe we could just, kind of frame for a moment for those audience members here and our panelists, just, a top takeaway, Kathy, from last episode that left you thinking, left you ruminating on that session. What would you say?
So from my perspective, what the truth that Dr. Isabelle Desjardins shared, that organizations such as hospitals are lacking KPIs, key performance indicators around mental health, and that was the takeaway, and the truth that was shared by Dr. Desjardins is actually something that organizations should consider. Like our organization, for example, we do have a KPI around mental health, not only for patients, but for employees. And I think all organizations should consider it. So that was my takeaway from last session.
Yeah, I mean, that was the big elephant in the room. I think you nailed it. I couldn't believe that was not part of strategy and leadership's dashboards, and then as you peel down that layer, I was really taken by the lack of appreciation and care for the interconnectedness between number one, mental health and physical health, and how those are undeniably tied together a lot of times. And then even more kind of interconnected was an individual's mental health status with that of their effect to the family members and caregivers that support that treatment pathway or that care paradigm or that mental health crisis in that moment. And so it became very clear that we have a long way to go at understanding how to care, certainly in the US, care for mental health and create a system around mental health, not to just isolate the individual, but really look at it comprehensively and collectively.
Yeah, exactly. And these points, that's what make the session so impactful. So there are challenges and opportunities and we need to extract the truth, and discussing this respective impact is what makes these sessions so valuable.
You bet. Absolutely. Look, before we continue, I'd like to just take a quick moment to acknowledge our great partners across the border in the province of Quebec.
Thank you to the government of Quebec and the Hospital Center of University of Montreal. As the coolest hotspot for innovation, we're proud to have the government of Quebec as a disruptive partner.
And without further ado, let's turn our focus to today's topic, aging in place. And to help us navigate that discussion, we have 3 incredible guests, starting with Dr. Sylvain Gilroy. I apologize if I mispronounced. French is definitely going to be a challenge for me, and one that I look forward to getting.
You're getting better, Michael. With. That's good.
Thank you,
job.
Kathy. Sylvain, you lead Domus Laboratory at the University of Sherbrooke, which focuses on cognitive assistance, medical monitoring, telavigilance for people with cognitive disorders, and specifically you focus on the elderly as well. So thank you for joining us. We can't wait to dip into your perspective and surface insights for our audience. We've got Dr. Heather Altman, a close colleague and friend over the many years we've been here in Chapel Hill and DHIT has existed, an adjunct assistant professor at the University of North Carolina Gilling School of Public Health, principal at Harmony Advisors, former VP for Community Outreach at Carroll Woods Retirement Community, and now full-time caregiver of aging parents. Thank you for joining us, Heather. And we've got Martin Ducharme, probably mispronounced again, but I hope a level of leniency for me. Martin is the Director of Business Development at AlayaCare. It's a organization focused on providing cloud-based software, helping home health agencies manage care visits at home, virtual visits, and remote patient monitoring. Thank you so much for joining us today.
My pleasure. Thank you for having me.
Oh, Kathy, I think you're on mute.
Thank you. Thank you.
There we go.
So what an exciting group. And just before we jump on and exchanging with this amazing panelists, I want to encourage participation from the audience, and we'll take time to take your question and answer them throughout the session. So please write them in the chat, and we'll be picking some of them from now to the end of the session. So let's get going with first questions for Heather. So Heather, you've gone from running community-based initiatives that support Aging in Place initiative, as well as leading the Global Aging and Technology Collaborative that included partners like UNC, MIT, and Cambridge, to now caring full-time for your parents, like you shared with us at the beginning. So how has your perspective changed or evolved regarding the challenges of aging in today's society now that you're the caregiver, or has it changed?
Yeah. Thanks for asking, and it's really great to be here. It's exciting to be with all of you. I love this topic, and you very kindly recognize the work I've done professionally, and now I'm fully immersed in personally. Both worlds I have loved. I often say now my journey in caregiving is field research for my professional focus, but in terms of my perspective, I wouldn't say that it has changed or evolved. Rather, it's sharpened. I've known about so many challenges and issues and even opportunities, but now I'm really living them daily. Two super quick examples as I think about this, my perspective is there's been more and more written about the expectation and requirement that family caregivers take on more intensive medical care of their loved ones at home. And I'm excited that Martin's part of the panel because he comes from that home care world and home health. But for example, post-surgical care, wound care, that's something that we've experienced. And so while an individual may have a few visits by home health, really the benefits are limited and families are expected to take on this care as well, this really intensive and even skilled care. And so what happens to those who don't have adequate support and resources? And I'm really living that firsthand, this change in expectations that families take on really intensive medical care. So that's one level. And then the second level is there are so many helpful resources out there. I call them tips and tricks and tools and things that really can make caregivers' lives easier, both from a low-tech perspective and a high-tech perspective. And so like many people right now in the pandemic, I'm completely obsessed with Amazon. I spend so much time on Amazon typing up my need to see if there's something that can help me. And amazingly, usually there is under $20 that I can have delivered within 2 days that can help give me some support. And so I'm amazed at the options. And so that perspective is also out there, that there are a lot of resources, but how do we get connected to them? And right now, Amazon is my, sorry, I don't work for them. I'm just a happy caregiver getting help.
And Heather, you shared the importance of the patient and caregiver experiential learning.
Yes.
In Montreal, we were, and I'm proud to say it, we were from the first to lead the importance of partnership with patients and caregivers. And I think this is key in supporting aging well at home, but even for the healthcare system. So thank you for sharing that, Heather.
Absolutely.
Sylvain, turning our attention to the technology and research lab that you're running, you design, implement, assess cognitive orthotics interventions for people with cognitive deficits like dementia, Alzheimer's disease, et cetera, particularly to the elderly. Through your lens, through the history of this established lab and your knowledge of these orthotics, what technology or solution have you seen deliver the greatest impact or have the greatest value delivered to both perhaps the patient and the caregiver, as we're kind of combining these two as we should? And what about in the future?
So we're designing assistive technology since almost 20 years. And basically what we do is using sensor networks and do some analysis and interact either with the elder or the caregiver. But throughout the years, what we discovered, in fact, is that technology alone is not enough. We need to be to work to address three pillars. So the first one is technology. So you have to have an assistive system, but we also have to work with health science, with the caregivers, with the clinical aspects, and when we are designing things, we have to rely on evidence-based research. And even with just health science, it's not enough. We also have to address the implementation of this technology in the organization or in the homes. And if you want to be successful and have a real impact, we have to address these three aspects together and from the start. And what is working is that it's not possible to design a technology in our lab alone and say, okay, this is a technology, just use it and that's it. So we moved to a participatory design approach, and the caregivers, but also the elders, and even elders with cognitive impairments, are involved from the start in the design of the technology. And it is really a co-creation process. And in this way, we have really a result that is used and is helpful for the person. And the other thing that we tend to underestimate at the beginning was the training phase. And it's not possible to cut on the training phase. We have to take the time it took to train the elders and to train the caregivers. So all our applications are also directed towards both sides of the middle. So for any application, there's a part for the elders and a part for the caregivers. And it works. It really works, and it's really helpful. And we have example of deployment where it's changed the life of people, and even people with severe cognitive deficit. And in the future, I see that we have to combine from the technological point of view. We have to combine three things: Internet of Things, which is becoming which will become very widespread, augmented reality, and also AI. And combine these three aspects to develop something we call a do-it-yourself approach. So in this way, the people will be able to co-design their own solution and then to personalize them. And they will be able also to share this solution with their community. So there is I would say the care-ready scenarios or solution will be shared, improved by all the community. So this is the way I see how to have an impact and what the future will be. And there are tremendous challenges we are facing.
Yeah, that's so on point and in alignment with DHIT's kind of operating ethos, which is first thing that needed to innovate was the development process, the operating model in which we deliver innovations and interventions to our community, where instead of building technology in a vacuum, we source the problem and extend the insights to, extract the insights from those that experience a problem, and then develop off of that learning system. So in fact, what you're building is a learning a system that delivers insights over time, where then, if I can then take your second piece, and correct me if I'm wrong, but I'm just connecting dots here. The key attributes from a technology perspective, IoT, augmented reality, artificial intelligence, those three things combined off of that insights engine or learning system then can allow for idiosyncratic solutions to solve individual problems. Is that accurate?
Yeah, that's exactly that, and I think that's the way to go. And it's very important to integrate the elders and the caregivers from the start, and to give them tools so technology won't be at the front place, but behind. And it will be tools like pens for people to design their own solution.
Merci beaucoup, Sylvain. Injecting some French.
Yeah.
So let's move on to Martin. So Martin, your organization provides home care agencies with a platform that services many needs. On behalf of your customer, what would you say is the most challenging problems associated with caring for the aging population?
Oh, that's I was going to say the million-dollar question, probably the multi-billion-dollar question. So home care, so everyone's trying to improve care, reduce hospital readmissions, cut national healthcare spending. We're all working towards that, partly because we know there's a growing demand coming from the increase in number of elders and more chronic diseases to manage. And obviously it's cheaper to manage care proactively in the home than having to deal with readmission and complications. Now, the interesting thing is, as we're all trying to work towards that, I see this as like, that's the game we're all playing. And when the game's on the line, you may have a champion that you're keeping on the sidelines, and that's home care, home health and home care. And the reason I say this is because it's still not perceived as a strategic aspect, I think, of healthcare delivery. And there's a number of roadblocks to implementing like home-based health programs at scale and in a way that it will replace eventually some of the institutional settings. So the obvious ones, obviously, is right now is lack of caregivers, low wages, and that comes with not being a strategic aspect of healthcare delivery and not being a valued contributor to care. And I think this also goes into the funding philosophy, where the home care programs will often focus on social determinants. They'll look at what are your medication discrepancies, your home safety issues, how are you able to navigate your environment, how do you access social services around it, which all are variables that don't necessarily exist in a hospital setting. So it's a slightly different way of delivering care. And the funding philosophy right now is more on value-added based outcomes in a controlled environment, which is, and it doesn't really reward all these other activities that are more, I would say, adapted to the home and less maybe traditional for a service model. And then on the operations side, I would say coordinating practitioners in different disciplines is a big challenge for home care. So we have nurses, we're going to have PSWs, we're going to have physios, we're going to have doctors connecting remotely. So that's a challenge. And that can be achieved with modernizing technology, as Sylvain mentioned. Creating enabling circle of care, which again doesn't exist in the hospital. Like, so how do we involve the primary care physician, the hospital for the specialist, the family? The family is going to be involved in this. So how do we connect everyone and improve the communication, the coordination? And finally, I would say tracking chronic diseases on an ongoing basis. How do we get data? How do we leverage the Apple Watch of this world and all the different therapeutics that are being built to better support patients in between appointments and shift towards more proactive medicine? So, and I think these are all the different aspects that are big challenges right now for home care. And I think you're probably looking for one. I think there's a number of ones that are challenging. But I would say the biggest misconception, or the thing that people tend to forget about home care, is that the challenge is not just changing the location of where we deliver care. It's not going from hospital into the home. It's much more than that. It's how do we build it not only into the home, but also into the lifestyle. These people are not staying in the same room, in the same house all the time. They will need to move. They will need to be active. There's daily activities. There's appointments to go to. So how do we build technology? How do we build our models into the lifestyle of these people? So I think this is probably what I would say about the.
And that seems to tie right to Sylvain's, operating model of allowing that edge data collection at the home, at the site to fuel the development of that individualized care system based off of exactly what you said, Martin. Let me ask you a question. Between Canada and the U.S., and AliCare, reaches both. Do you see any differences, core differences that are inherent in the U.S. market versus the Canadian market, or is it servicing, is the home, is the individual, are the problems the same?
I think the problems are the same, because in both cases we're talking about transforming the way we're delivering healthcare, and that's no different in Canada and the United States. So the struggle with caregivers, wages, quality of technology in place, that's the same in both countries. I would say the level of complexity, obviously, in the United States with different state regulations around electronic visit verifications, around the integrations for billing, for claim management, so it's a lot more fragmented in the United States, and that creates more challenges for nationwide care providers and for technology vendors, for sure. That's probably one difference. But I see an appetite to adopt technology into the home in the United States that is greater than what we would see in Canada right now.
So we have a question from Halima Aishun. Here's the question. Please, is there any example of concrete e-health application which right now combines IoT and AI? Who wants to get a throw at that? Maybe one example. Martin, you're nodding. Maybe Sylvain also is coming forward. Go, Martin.
I was just saying, there's a number. So what people are trying to develop now is an ability to monitor patients passively through an ecosystem of technologies. And that's usually going to be something like a mobile app with a cloud system, so that all the information can be sent to the different people involved in the circle of care, and some device, IoT device, that will be collecting the data. And then what we're seeing more using the apps or using voice, for instance, voice interactions is being used more and more when elders that don't want to use keyboards and screens. The reason we use these, supplemented by AI algorithms, is to interact with the patients. And the reason we want to do that is we're 10 years ago, we were trying to get data. And then 5 years ago, we went to say we want to get accurate data. So Johnson & Johnson, Humana, Optum, all these companies were looking at, how do we get relevant data? And now the challenge is, how do we contextualize data? Mm-hmm. And that means if you're diabetic and you're above your targets, is there a reason for that? Or should we be worried because you're doing everything as usual? And that's not the case. So you have a number of companies like Vivante Health in Texas does something for digestive irritable bowel syndrome. Octave Bioscience in California does something great for MLS. Mm-hmm. So so different chronic conditions. There's all kinds of great companies like that, and obviously the big ones, the GE Healthcare, Philips, and Siemens, and all these companies are developing that. But everyone's trying to develop that ecosystem of connected objects, cloud, and data flows supported by AI and machine learning.
In the long-term care and senior living industry, the group that I see that seems as really focused on this is actually a Raleigh-based company, so not too far away from where Michael and I are. It's K4 Connect. They have been trying hard to create this platform that works with the Internet of Things. Is really, they were trying to do at one point very home-based. What they've ended up moving to is community-based, and by community, it's, I don't love the word facility-based, but institutional facility-based. So in senior living communities, how can they connect all kinds of different information, as well as lights and lamps, and then connecting you with your providers and your loved ones and your people at home and your caregivers coming in. So they're the ones that I hear, and I've been watching over the last few years, try to create this platform to be that holding. I know we, in this group, I know we love the word ecosystem, to create this ecosystem for all these. I don't know how much AI they've put into it, but they seem to be the folks that keep growing, and they have good backers. That's the other thing. Yeah, I've been watching technology for a few years, and then I just stopped, because you see new ideas come, and then within a year or two they go away. Either, you know, their initial funding ran out, or they didn't have enough users. So frankly, the people that I'm paying attention to are those with really big financial backers behind it, who have the time and the resources to fail and then fix it and bring back a new version. And so, which also pushes, I think, the small startups out, but it's those that really have the ability to grow with the industry.
Thank you, Heather and Martin. Yes, thank you. Thank you, Heather and Martin. We have a question. We have 3 questions. I will tackle the second one for Sylvain. Oh, yeah. Sylvain?
Yes, I have two concrete examples of combining AI, IoT, and in some cases augmented reality. The first one is for a meal preparation, and the other one is about giving the right service to the person. So we developed a system which help people with cognitive deficit for cooking, and to be sure that it is safe. We deployed that. We co-designed the system with them. We deployed that system. At the beginning, the person was not allowed to cook in their home, and using the system, she learned how to cook safe, how to do safe cooking, and how to plan the operation and all stuff like that. And a year later, we removed the system, and she was able to stay at home and to cook by herself. It was okay. This is an example how sensors, AI, and assistive technology feedback to the user can help people to stay at home. And the other example is it's with our care center. So the caregiver was supervising an elder woman, which was starting to have some cognitive deficits. And there was a stove, and they asked the woman, are you cooking? She said, I'm using my stove every day, everything is fine. The son of the woman was saying, it's not safe. My mother need to have meal delivered at home. And the daughter was saying, no, everything is okay, don't worry. So we put the sensors, we do analysis, monitor the habits, and we discovered that the person was not using the stove, but she was eating differently, taking small naps, small snack, and that were distributed over the day, and she was not losing weight. So the care center decided to not provide meal delivery at home, which was good for her, because with that, she was still using her cognitive capacity, which means that it has improved the time she was able to stay at home. And indeed, what they say is that normally this woman, after 6 months, she would have been transferred to a care center.
Yes.
But with that, she stayed 18 months at home. So it's made a great difference for her. So
yeah, thank you for sharing this, Sylvain. So I have one other questions from the public, from Jonathan Zell from Genèse. Maybe one of you can answer. How do you get the elderly population and their caregivers to utilize technology to improve outcomes? Concretely.
I think
Heather.
I think the key is that you need to have someone championing it in the home and to see that it has value. So for me, I'm home. There are things that I want to be able to connect my family with or shop or resource. And so, but I'm a champion. I know there are things out there. And so I can help and then help simplify it for those who need it. On the flip side, my father is a professor. This is his space where he teaches. For him, he already has the motivation and the champion to make sure that he's got Zoom down, that he can do his telehealth visits. And so you figure out who's your champion and who has the motivation. Because you can have lots of technology and fancy things, but if you don't have the motivation to do it or the ability. So in one end, I'm the motivator and I'm excited about it and I need the support. In other end, my father's really excited to stay connected and to be able to do his work. So you just have to find it. I think it's really complicated. If you don't have someone who's going to champion in the home and you don't see value to it, then like any innovation, and if it's too complicated. So, I'm looking around the desk, things that we're used to, if we're used to picking up a pen or we're used to a TV remote, it's got to be similar. If it's too complicated, and that's why I watch a lot of things fail. It's just too much. It's too difficult. It's not worth it. The juice isn't worth the squeeze, as one of my colleagues likes to say. So it's really individualized what's going to work and how.
Absolutely.
If I may, it's
sure.
You're spot on, Heather. There's two rules. It needs to add value, as you mentioned, and it needs to add value for the user. Right. So nobody's interested in like picking up a technology that's going to help the physician at the hospital only. People want to see how it makes a difference for them to participate. Second thing is, and that's the cardinal rule in any technology design, is understand the user experience. Build the technology so that it fits their lifestyle. Mm-hmm. If you're asking them to monitor something regularly in a day, don't create a device that's going to be parked in a room and every time they have to go to that room to, collect the data. Build it into like an Apple Watch, for instance, right? So understand how these people are living so that you can develop technology that becomes almost something they'll forget, right? And then it needs to add value in a concrete way also for the patient, not just for the providers.
Mm-hmm.
Yeah, it makes perfect sense. Look, I'm going to share a personal story for a moment to extract and surface what I feel is really perhaps the potential negative of aging in place if the situation's not cared for. COVID really exacerbated and accelerated a unique situation in my family. For 3.5-4 months from the start of COVID till middle of the summer, my parents were living by themselves about an hour away from my house. And of course, we went into isolation, right? The fear of contracting COVID for my parents was extraordinary. The unknowns equally, but limited interaction and connectivity outside of phone calls with children was the reality. So in a lot of respects, this kind of mirrored what living at home in isolation might look like for aging parents. 4 months into it, my father lost 35 pounds. He was experiencing extreme obsessive compulsive disorder, anxiety, induced stress. His cognitive abilities were almost non-existent, to the extent that without really thinking twice about it, my wife and 2 children went down to grab grandma and grandpa and bring them into our home and say, okay, we'll figure it out together. And then what ensued was about a 2.5 month extensive process of caring for both my parents, but mainly my father from a physical perspective, and then my mother from a mental perspective. And what I saw was this again, getting back to the my initial comments about last episode and the connectedness between mental health and physical health. I can't I'm so aware now of the significant challenges of aging and aging in place and aging in isolation, that I'm scared and I'm nervous and I don't know really, you know, the extent of what this looks like when you know, our baby boomers and the rest, you know, age up, and we are the caregivers, the 90% of the caregivers that are supposed, you know, so, you know, are we fighting towards connectedness, control, and communication with our with the aging and the elderly? Or what is it that is sought after to anchor a home and parents? And I'm going to direct this to Heather because you're living it right now. You know,
yeah.
I'm sure you can empathize with my situation.
Completely.
What's, you know, just explain maybe through your lens, like what's going on there?
Yeah, I think, you know, there is this, I don't want to say it's a fantasy because there's a lot of reality to it. There's a dream, a love about aging in place and people thriving, and so many can. But there's also the reality where a lot of people are, you know, failing and frailing in place, and they're not thriving because it is a really complex situation. And so you have to start to really piece it apart. What is it that people want, and what is it that people need, and can they do it in their home? Years ago when I was teaching about aging in place, and it's such a big topic, you know, we say it like it's one little thing, but it's a really intense topic. And I found this really simple chart. It was in like an Australian journal, and it talked about the dimensions of aging in place discourse. What do we really mean by aging in place? And I was almost embarrassed to show it to my students because it's so simple, but I think it really talks about it. And it says, you know, you're on an axis. When you look at aging in place, you have the physical, structural issues, literally what's going on in the home, what's going on in the community, what's the buildings, what are the sidewalks like, literally how is the community and the home physically prepared to help someone age in place. And then on the bottom is this, or in any direction on the other end, is the social, emotional, the interpersonal, the relationships, the engagement. And so there's a whole continuum. When we talk about aging in place and what are the supports, are we talking about and you spoke so beautifully about it with your dad. Now there, in those cases, it might be more the social relationship supports, but also are there things going on in the home that's either helping or hindering? And so that's one axis. And then the other one is what are the supports either from a government perspective all the way to grassroots? Are these neighbors coming in? Are these, I live in the South now, so there's lots of talk about congregations, the faith community. Where's your support system from a grassroots level, all the way to where are the supports from the government level or the more traditional structures? So where do the healthcare professionals come in? What are the structures? So I put that out there because when we talk about aging in place, there's complexity all the way through. Where's the support coming from? What are the problems? And as you start to look through it, you then can say, okay, well, what do we need to be successful and on what end? Because you can be super successful and really socially active in a home that can't support you, or you can have a fabulous home and be completely isolated and not have food and not have that. So it's much more complex than people realize, and it's easy to say, oh, I want to age in my home, but what does that mean, and what does that mean for loved ones who are kind of circling around to try to support that?
Thank you, Heather. Yeah, very, very, very great insight. Kathy, I think you're about to.
Do you want me to? No, I had a question. Do you want me to take another question from the public? They're active today.
Yeah. Well, please let's include. Sure.
This is a question from Jeffrey Carey from Professor Gilroy. Sylvain, to expand on your perspective on the wireless wearable sensor networks and the convergence of both technology and human-centric intervention, where are the current unmet needs in the Canada market? And I'll keep the second question of the magic wand to the end. Go ahead, Sylvain. Go ahead, Sylvain, for the first one.
Okay, I don't know to which extent I can answer that question. So I think there would be, we need to find a good balance between wearable sensor and sensors that are installed, because elders do not wear the wearable sensor all the time. just have to think about the push button that is put on a necklace. So usually they put that into the drawer and they forget about it. They don't wear it. So we need to combine these both sources of information. And for wearable sensor, it is very useful when they go, for instance, for outside. So there are a lot of systems that are available that can be used to that, and we need to combine that to provide a full support to the person. Okay.
Thank you.
My colleague can add something to that.
Thank you, Sylvain. For sure. Did we, Michael, another one? Yeah. Okay. Go ahead. Next, another one from Suhail Perry. One of the big gaps right now with seniors is their lack of knowledge of internet and technology. Do you have any idea how to bridge it, given the current social distancing and lockdown? Martin, maybe?
Sure. That's been the question for the longest time. One thing to keep in mind is if you look at people who are in their, a lot of people in their 70s were probably active professionals when the internet came around. So progressively, we're seeing people that are, over the age of 60, 65 that have some functional knowledge of the internet or mobile devices. Now, when it gets to people over the age of 80 and 90 years old, then there's two ways. Part of it is the implication of the family or the live-in caregiver, and the other one is going to be around designing technology that's as simple as it gets and requiring as little interaction as possible. So the example of voice interactions, for instance, using Google Home or Alexa, building voice skills is far more intuitive for somebody who says, if the skill says, have you taken your medication today? Yes, I have. Are you feeling better or worse than you were, like, let's say, half an hour ago? You don't want to grade it because then you become a medical device, but you want to say, you can still track some of the progress or how things are going, but you make it in a way that's intuitive for them. So that's one way to do it. But it's what we've seen, at least with the home care agencies that we work with. We implemented virtual care, partly to protect the home care workers. In other words, don't go into the home if you don't have to, do it virtually. But we've seen a very rapid adoption of that technology by elders over the age of 70, about 5 times more than what we expected. That's 72%. So why? Because it's often coming in as a single click. And this is why Zoom, for instance, got so much adoption. You don't need to install anything. You click on it and it opens up. Yeah. But it is an ongoing challenge for sure.
Heather, Sylvain, any additional thoughts there?
Well, I saw, and I also saw in the chat really quickly, connecting about a question about telehealth, and I have to say, I think it's a savior. I'm such a fan of it. We use it so much. It's been wonderful for me personally, for my parents. We can have group visits with doctors. The responsiveness that I'm getting through email, and also, there's a lot of things that even I've gotten really good, thanks to a good clear iPhone, to take pictures of what's going on with my parents. I have to kind of keep them hidden because it's like wound pictures, and then I send them to the wound care clinic, or I send them to doctors and how should I treat this, and they get back to me. So I'm actually finding a lot more the responsiveness, as opposed to, we can't see you for 2 or 3 days and somehow I have to figure out the logistics of getting my mother there. No, she can stay in bed, dad can join, we can do things as a family. I think we're getting better care that it's coming into the home, and sure, it's through a computer, but just like we're seeing each other, and I feel like we're having an intimate conversation, and we're really diving in. So some people are talk about going to the telehealth visits as a problem, but I think it's been a lifesaver, especially right now when we don't want to be, seeing.
Absolutely.
I would add.
Please, Sylvain.
I would add just another small aspect. So we have also to take into account the people that come into the house, and to be sure that people have trust and that it's safe. For instance, with a nonprofit organization, we have a project which would manage visits of people, taking into account the risk of having COVID or not. So these are also applications that support the caregivers and to be sure to foster the social interaction.
Mm-hmm. As we talk, I have two wonderful women on the other side of the door wrapped in PPE. I don't know if you use the same term in Canada, that protective equipment. They have shields, they have gloves, and they're, you know, taking care of my mom and giving her a massage and taking care of, you know, it's their home health, the CNAs and nursing assistants. And so there is a time when we say, you know what, it's important enough to get that physical touch. I know there's also a question about touch coming in. And there, at some point you say, this is important, and it's, I'm not going to say it's worth the risk, but you take a sort of thoughtful risk. And these wonderful women are just sweating, they're covered in things, but I know they even in that, the caring touch is there.
So true. Thank you all. We're gonna move on to what we call the rapid fire questions. Even though I'm gonna cut one of the questions and just leave two, just because of time. This first question is about what do you know? Give us one stat or one thing that we probably don't know that you want to make sure we're aware of. And I'll start with Sylvain, go to Heather and Martin. Sylvain, what's one thing that you would share with us that we, the audience, likely are unaware of?
For me, what we discover is that people, even with severe cognitive deficit and no prior knowledge of assistive technology, they are still able to learn how to use them and to integrate that into their life. And this is a great opportunity to, if we provide appropriate training, they are able to remain at home and age at home.
Thank you, Sylvain. Heather?
I know Martin might speak from the Canadian perspective, but in the United States, we currently have 4.6 million direct care workers. These are our nursing assistants, the home care individuals. This workforce is now larger than any single occupation in the United States. And despite this growing need and the importance, they are poorly compensated, an average wage of just $12.80 per hour for this critically important work. So,
boy, that just gave me chills. Oh, that's a deep one to digest. Martin, how about you? What can you share with us?
I was going to go with something else, but I'll piggyback on what Heather said because I think it's important. When we say it's a large workforce that's underpaid, there was a presentation earlier this year by Rick Polak, the CEO of the American Hospital Association, and with a representative from Medicare, and I forget the name, but he was saying, with all this happening right now, with the suspension of elective surgeries and procedures and all that hospitals have to do for COVID patients and other patients that are stuck in the hospital where we could decant the hospital, we would. They're losing $50 billion a month right now. Oof. Combined with that is that Medicare says, well, maintaining a patient at home versus maintaining a patient in the hospital is 50 times cheaper. Yeah. So it's an easy number to remember, which is why I thank them for picking that. But like, it is the 50-50 rule applied differently, but 50 billion a month lost on the in the health systems. Meanwhile, you have an ability to transform your healthcare system towards something that currently costs 50 times less. Now, should wages be higher? Should we increase the work that we do on certification, training, modernizing technology to do better care? Absolutely. So you're never going to be at that 50-to-1 ratio, but you're still going to have, a quite important economic incentive to think of care differently.
Amazing. That's mind-blowing. And might even spin off a whole episode onto itself for us to jam on. All right, last question. I'll start with Heather, then we'll go Sylvain, then Martin. Heather, if you had a magic wand, where would your focus be? What would you solve with that one wave of that magic wand?
Okay. So with the magic wand, I would have people so many are in denial about aging and about what their needs will be in aging. And so my wish is for people to approach aging as they do their other life phases, with the same thoughtfulness and preparation and excitement they put into buying a house or starting a family, or I just sent a kid off to college. That same excitement, and also realistic thoughtfulness. How are we going to do this? And so that way they're not making decisions in a crisis. So I'd like to see us sort of an intellectual, psychological, emotional paradigm shift where people just accept it, the good and the bad, or the challenging and the excitement, and just approach it like they do other things.
I love that, a mental frame shift. Sylvain, you have a magic wand now. What are you waving, and where is it focused?
In fact, it's I will address a general issue. So I think I would build a shared view and agreement on data ownership, data sharing, and data privacy. And I would develop the technology and the infrastructure that will enable to implement that view. So this way, I think it would foster the development of assistive technology and the acceptability and use for aging at home. This is, I think, a key issue that we have to solve in our context of aging at home.
I love that. I love that. It kind of, I always think of this time period as 1920 in the 21st century, where cars are just coming out, and like we're still trying to make horses faster, but like we don't know even the infrastructure needed to move cars and transform how we transport ourselves to and from. So I think you've nailed a tremendous area of need. Martin, over to you. Magic wand. Can shine it over and wave it on what?
I would say adoption of technology. For the caregivers going to the home, for the patients, for the agencies, for the retirement homes and nursing homes. I think it's technology across, and not because I work for a technology company, but it's just recognizing that there's going to be more and more elders living longer, and an increasing need for services. And combined with that, a limited supply of caregivers. There are limits to that, and there are limited supply to money. So more money, more caregivers is eventually going to reach its max. And then so the only way that we're going to be able to scale this is through technology. And that's going to be done in two ways: in engaging the different disciplines and engaging the patient and their families into care management. So around communication, collaboration. And the second thing is going to be around the data that we can collect with remote patient monitoring and the AI algorithms that support clinical decisions or support decisions for, let's say, a diabetes patient looking for recommendations on what they can eat when they're, above their targets, right? So data is going to be super important to support the patients between their appointments and to be a little bit more proactive in the care that we're providing.
Totally. And at that point, thanks, Martin, and thank you, Heather, Sylvain, for getting us focused on perhaps where the biggest opportunities are to solve against. Martin, I'd like to invite you to share, for a few minutes, a quick case study, use case from Elia Care of perhaps, what's one problem, what's one area that you're solving right now that you're seeing impact.
Yes, and we don't necessarily have a slide here, but I want to talk just in simple terms around expanding on the remote monitoring. So there's in chronic conditions. What's been done in collaboration with different health systems in Canada and the University of Toronto, that was our initial pilot study around monitoring patients with COPD and chronic heart failure. And we're doing that with a bit of the ecosystem I mentioned before. So we're going to have mobile apps, virtual care, video conference, ways to interact with the patient, but also ways to collect data passively and to contextualize that data based on what were they doing at that time, how are they feeling, can we correlate things with their vitals, basically, how do we start not being reactive as we would be in a hospital and say, like, patient comes in, I have a problem to solve to get them out, but more shifting towards a proactive, ongoing way of managing chronic conditions. And what we've seen over that period of 6 months is it led to 73% reduction in ER utilization, which is a big thing, as I mentioned before, in terms of cost, and 64% reduction in the number of hospitalizations. And overall, the number of patients that required at least one hospitalization went down from 57 to 22%. So this made a big difference. And overall, in terms of cost, in terms of medical burden on the hospitals, while also providing the, I would say, the evidence or the evidence of outcomes that will eventually force governments and funders like Medicare, Medicaid, different programs to say, well, this actually makes a difference and we should be participating in enabling these technologies in the home.
Yeah, that's wonderful. A great case study and shows real impact and real value to the system.
Mm-hmm.
Kathy, were you going to add anything?
Maybe you know some keywords. I like the last exchange on the rapid fire question. So, I mean, we talked about shift of paradigm of aging is a nice event in life. I love that. Data ownership, data privacy, that's another good point. And finally, Martin, adopting technologies. And I would add social innovations too. If you want to age well, there's different kinds of innovation, and technologies at the center point, but there's also different types of innovation. So thank you for sharing all of this. It was very interesting. Michael, up to you.
Absolutely. And look, we're at that time of the hour that I have to say thank you very much to our panelists on behalf of Kathy, myself, the government of Quebec, Center Hospital of University of Montreal, CHUM. We are so grateful for your participation, for bringing this in really robust and heartfelt conversation to our communities. We're going to obviously, we have recorded this. This will go out live, or not live, but in a recorded fashion out to our through our channels. So thank you very much. Please stay tuned for our next series, our next episode, November 6th. It's going to be focused on pediatric care. We will be announcing our panelists very shortly, probably middle of next week. And again, just tremendous wraparound hug to you all. Thank you so much for sharing and delivering such incredible insights. Thank you so much.
Thank you for having us.
Thank you.
Wonderful. Well, we're tuning out now. Till next time. Thank you so much.
Bye,
Take care.
Thank you. Be well, everyone.